Yeah, live.
Okay, thank you. A very good evening, all of you. Wishes for the majestic Rath Yatra of Lord Sri Jagannath, Sri Balabhadra, and Subhadra. So I hand over to Dr. Srimanta Behra, our President OSOS, to welcome the participants. Over to you, sir.
Thank you, Dr. Sarmita Behra, as a scientific committee chairman. Nice job. I welcome all the members of OSOS to participate in the web series 5 of our society, and it is nicely prepared by the scientific committee. Their hard work is visible. I also welcome all the members of AIOS, Dr. Swati, Dr. Bhaskar, Dr. Hijab, and Dr. Manoranjan, who has give their valuable time to increase the standard of the webinar and give their valuable advice. Last but not the least, Dr. Rajit Babu Maji, who is the past president of AIOS, kind enough to give always his time to support our scientific activity, and is really observing that our science OSOS is gradually growing. Thank you, Dr. Babu. Over to Dr. Samit.
Thank you, sir. So, like the Rath Yatra today, which represents transformative passages through darkness towards divine illumination, just as the magnificent chariots, they carry the deities from their sanctum to bless countless devotees. The ophthalmologists also guide each trauma patient through their own arduous pilgrimage from injury to restoration. This navigates the complex pathways with precision, compassion, and dedication. The rhythmic pulling of the chariot ropes by thousands of devoted hands parallels the collaborative efforts required in ocular trauma care, emergency physicians, nurses, subspecialties, and rehabilitation teams, all united in purpose. As Lord Jagannath's annual sojourn symbolizes renewal and universal accessibility to the divine, the emerging recognition of ocular trauma as a distinct subspecialty would possibly one day represent a collective aspiration of all of us. Thank you. Over to the moderator, Dr. Devi Aishwarya Das, to take the program forward.
Yeah, good evening all. Blessed Rath Yatra to all of you. When we are, as we begin this Cornea episode of this ocular trauma series of OSOS Vidya, Vandate, Amritam, let me first introduce our esteemed panel from outside of Orissa. Though Manoranjan is staying outside, he's still a part of Orissa. So can I just share my slides a little? Just take half a minute. Yeah. So we have Dr. Hijab Mehta. She's head of Cornea, Cataract and Refractive Surgery Department. She's from Infinity Dr. Agarwal's Eye Hospital, Tardio in Mumbai. And she's done a Cornea Fellowship and was adjunct faculty at LVPI Hyderabad before coming over to Mumbai and joining Infinity.
Thank you. Thank you, Dr. Aishwarya.
Thank you. Welcome, Dr. Hijab. And next we have Dr. Swati Tomar. She's right now Director Consultant, Swanitra Eye Hospital in Jaipur. She's Medical Director, Eye Bank Association of Rajasthan. She's Professor and Head Cornea Services, Department of Ophthalmology, NIMS University, Jaipur. And she was also an LVPI Fellow and Adjunct Faculty at LVPI, Hyderabad. Welcome, Dr. Swati. Then we have Dr. Bhaskar Srinivasan, and he's Medical Director, Code Eye Care, Chennai. He was Senior Consultant, Cornea and Refractive Services at Sankara Netralaya, Chennai. His areas of interest include ocular surface disorders, K-PROs, LKs, and refractive surgeries. He has over 100 publications in index medical journals. Welcome, Dr. Bhaskar.
Thank you, Aishwarya.
And we have Manoranjan, Dr. Manoranjan Das. Because he is my classmate, I tend to call him Manoranjan. So he's Professor Cornea and Refractive Surgery Services, Arvind Eye Hospital, Madurai. His specialization in corneal transplants, EK, keratoconus, and K-Pro. He's trained in DALC, DSEC. He's trained in DALC. He's done observership, trained in DALC and DSEC from Central Pennsylvania Eye Institute, Hershey, USA. He has done an observership in K-Pro at Massachusetts Eye and Ear Infirmary in Boston, USA, and femtolaser refractive procedures at Bascom Palmer Eye Institute, USA. Welcome, Dr. Manoranjan. So he will also be one of the speakers. Before I end this, I would also like to introduce you all to our expert panel from inside Orissa. We have Dr. Shweta Dhiman, who is also mentor for Dr. Raj Kenia. She's working as pediatric ophthalmologist in JPM Rotary Eye Hospital. We have Dr. Shrikant Saw. I think he hasn't yet joined. He's medical director, LVPI Bhubaneswar. And we have Smruti Priyadarshini, the budding young cornea gun from Orissa. And she's a consultant in LVPI LVPI Bhubaneswar. And we have Dr. Vidisha. I don't see her. We have Dr. Vidisha. She's a consultant. Yeah, she's a consultant at Center for Sight in Bhubaneswar. We have our mentor and guide, Dr. VNR Subudhi sir. He's a director of Ruby Eye Hospital, and he has been a professor and mentor to most of us here. And we have Dr. Jayashree Dora. Yeah, she's Dean and Principal Vimsar in Burla. And she's also the head of Department of Ophthalmology in Burla. So thank you all. So now we will be slightly changing the order because Sakshi has not yet been able to join. I think Dr. Smriti will be able to coordinate with her. I have a PPT with me. In case she wants, I can present and she can join in from her mobile. So please coordinate her with her. I've also messaged her. So we'll have a first presentation, Dr. Raj. Please try and restrict yourself to 7 minutes.
Thank you, ma'am. I'll share my screen. Is my screen visible?
Yeah.
Yes.
Good evening, everyone. My name is Dr. Raj Kenia. I'm a second-year DNB resident from JPM Rotary Eye Hospital, Cuttack. I'm honored and grateful to the Odisha State Ophthalmic Society for letting me be part of this platform and letting me present in this in this esteemed academic series. My case today is titled Adhesion and Disinsertion: Navigating a Complex Case of Anterior Segment Trauma. A 55-year-old female from Jajpur, Odisha, had come to our OPD with a history of trauma to the right eye with a wooden stick 4 hours ago while working in the field. The patient reported sudden onset of pain, excessive watering, photophobia, and blurred vision in the right eye immediately following the trauma. In her past ocular history, she had a history of xanthomatous fever in childhood, which led to development of bilateral whitish opacities. There's no history of previous ocular surgery. In systemic history, she had no known systemic illnesses or diabetes or hypertension. On her general examination, her vitals were stable. She was conscious, oriented in time, place, person. There were no signs of trauma elsewhere. Her visual acuity in the right eye was hand movement, and in left eye was 6/18. Her face and ocular adnexa were normal. In the eyelid, on slit lamp examination, her lid was swollen, her conjunctiva was congested, her sclera was normal, and adherent leucoma measuring 5/4 millimeter inferiorly from 4 o'clock to 7 o'clock was present, and a full thickness corneal tear at 4 o'clock adjacent to the leucoma with iris prolapse was present. A stromal opacity 3/2 millimeter was also present at 9 o'clock. In the left eye also, an adherent leucoma measuring 3/3 millimeters was present inferiorly. On the anterior chamber was flat, and iridodialysis extending from 11 o'clock to 4 o'clock was present, and an iris prolapse to the and the iris was prolapsed to the corneal bone. The pupil was irregular and distorted, and the lens had cataractous changes, and there was phacodonesis. The fundus was of no view. For investigations, random blood sugar and viral markers were sent, which were normal. The plan was a right eye corneal tear repair along with iridodialysis repair. According to the Birmingham trauma terminology, the patient set into right eye open globe penetrating injury with an ocular trauma score of 70 at a visual acuity of hand movement. So, as you see, the MVR entry faced resistance due to a soft and hypotenuse blow. Pilocarpine was put through the main wound and the iris was repositioned through it. Viscoelastic was put through the wound, but the iris was still prolapsing, and hence sutures were taken to stabilize the wound. 10-0 nylon sutures were used. As the sutures are taken, you can still see that some of the iris was getting incarcerated in the wound. It was because it was still incarcerated in the adherent leucoma, through which we faced the challenge. Once the globe was stable, we used an iris depositor to unroll the iris, flatten the iris, and reposition it. You can see the keratome entry was made easier. A peritomy was done with cautery, and now a 2 millimeter scleral tunnel entry was done to prepare for the hangback technique. An IOL forceps was used to stabilize the iris, and now a needle was passed through the iris, and opposite to it, another 26 gauge needle was used to externalize the suture. A similar thing was done 2 to 3 millimeters away from the first side for the other end of the suture, and now the hangback technique for the first side is complete. The suture is knotted and buried, and now the iris is reposited, and the peripheral iris is fixed to the stoma. Now we do a peritomy at the second side. A similar procedure of 2 millimeter scleral tunnel was made, and the IOL forceps was used to stabilize the iris, and again a needle will be passed through the iris, and the suture will be externalized. Similar for the other end of the suture also. Hence, the hangback technique was complete. Once the hangback technique was done, a new pupil was formed just above the opacity. The iris which was there at the suture sites was cut, air bubble was given, and bandage contact lens was given. Right. On post-operative day 1, the right eye vision was hand movement. IOP was 18. Right eye bandage contact lens was in place. AC was formed, and there were intact sutures. Cells were +2. Treatment: the patient was started on moxifloxacin eye drops, prednisolone eye drops, homide eye drops, ciprofloxacin tablet, and aceclofenac tablet. On post-operative 1 week, the visual acuity at right eye was hand movement. Right eye pressure was 70. The AC was formed with intact sutures, shallow AC, and an intermittent cataract. A B scan was done at 1 week, which revealed mild vitreous hemorrhage. The X-ray orbit, AP and lateral, was done, which was normal, and the patient was planned for cataract surgery after a month. So what were the challenges we faced in this case? A shallow anterior chamber and hypotenuse blow limited our working space and difficult to maintain the AC depth. The iris was adhering to the leucomatous corneal scar, which hence required persistent maneuvering. And as the iris was adhering to the corneal scar, it required a lot of manipulation of the iris. The iris prolapse to the corneal tear was prolapsing even with minimal visco and not overfilling the chamber, and the iris was trapped at the suture site. So what were the key takeaways of this surgery? The goal of the surgery was to restore anterior segment anatomy and reconstruct the pupil to optimize the visual axis. Centrally reconstructed pupil improves the image quality even with corneal scarring. It helps reduce glare, photophobia, and monocular diplopia, and the critical step in maximizing visual rehab when a definite cataract surgery is planned later. Right. So I would like to ask the experts, the panel, these questions, that how would they approach this case? What surgical approach would they have preferred? And what other preoperative planning and evaluations would they do before proceeding for the cataract surgery of the patient? Thank you.
Thank you, Dr. Raj, for sticking to time. That was nicely presented. A quick word from Dr. Shweta, who was a mentor for this case, and then we'll go over to the experts.
Very good evening to all. I would first like to thank Devi ma'am for including me into this webinar. I'm very privileged. I'm privileged to have being invited as a panelist in this webinar because I'm going to learn from the experts of the cornea here, including the moderator. So there are certain points I actually wanted to highlight in this case, and I really want all the experts, including the moderator, to give their opinion regarding the agreement and disagreement regarding those points. So the first point was, when do we do manipulation from the corneal tear area, which is actually not advisable. Since you have seen in this video, the globe was very hypotenuse. And when I was holding the globe with forceps and trying to do the entry with the MVR, there was corneal infolding. So I didn't use the forceps and I tried to do the entry with the MVR. But rather than entry, it was making a corneal tunnel and a kind of pinpoint entry from the tip of the MVR. And through such tunnel, I think viscocannula will not go. Injecting pilocarpine, doing any manipulation will cause DMD. So I was forced to use the corneal tear area. So what is the expert opinion regarding this? When do we use the corneal tear area for manipulations? Are we really forced to do in these such cases, or it should not be done at all? Or is there any way to do it to maintain the anterior chamber depth, like injecting viscoelastic or pilocarpine through some entry, something else?
Dr. Swati, if any points on this?
Shweta, I think it's a very well managed case and the end result was good. But did you do a B scan before intervening? Did you do a light B scan?
No, ma'am. Actually, the patient presented just at the end of the OT, so I directly saw the patient
Right.
on OT table. So it
So
was
it
not
is
done.
always advisable to do a B scan at least, you know, to know the status of the choroidals or the retina, because you said it was too much of a hypotony. And obviously, when you go through an MVR and and if there are choroidals at the back or if there's an RD, then that'll, you know, incite kind of a expulsive also probably. And also you can push in a lot of visco from the site, you know, from the corneal wound, and make a little globe a little tighter so that the entry to MVR is not too much of traumatic. Also, I think the repair of iris was. It just depends on the technique that you use, and it was well done. But also to know the lens status is very important, that you know we at least see the fundus. Where is the lens? Is it inside or it has come out? So it's important to investigate better. Yeah.
Dr. Hijab, any thoughts on that iris repair and the pupil reconstruction?
No, I think it was done quite well. Simple technique, done quite well. And yeah, maybe in this case, because the wound was limbal, it was easier to inject the visco from the side of the corneal tear. After you form the AC a little bit, then you can use a sharp MVR. So normally I'm used to using money MVRs, which can enter through any eye. So that's not a problem. But otherwise, normally if it was a plain corneal tear, then it's very difficult to, not the best thing to inject the visco through the corneal tear. It's always recommended to inject from the limbal area so that you don't cause more damage and don't cause a DM strip in the region of the tear. And V-scan, as Dr. Swati pointed out, like before taking up the patient, having a V-scan, explaining the prognosis very clearly, that it's only a wound repair. This is not for, you may not gain much vision. The visual rehabilitation will occur later. So all those things need to be discussed, investigated before taking the patient in the theater. And cataract obviously will be planned later, much later. We'll have
Shweta, what was the duration between the
4 hours.
injury and repairs?
So 4 hours.
4 hours only.
Yes, sir. There is another point I wanted to highlight. Actually, this was a case where there was adherent leucoma and the quality of the iris was little floppy. So while pushing a little bit of viscoelastic from the main wound, the iris was again and again coming out. So what we intend to do in such cases is to keep the iris inside the anterior chamber as far as possible. If not, landing up in peripheral anterior synechia. If not, landing up in corneal wound incarceration, but not allow iris to come out. Otherwise, the risk of end-off is there. So there is another option. We can do iris incision. If the iris B is very notoriously, it is excessively floppy, then we can always incise it. But there was a 6 o'clock hour of iridodialysis already there. So I didn't do any kind of incision. So is it okay to have this iris incarcerated into the wound?
No, but you could have made a good MVR incision elsewhere and use the viscoelastic so that AC will always remain deep and the iris will be in place. Every time you reposit the iris, there will be a tendency for iris to come out. Luckily, in your case, the iris has gone in very well. But it's not always the case. And the iododialysis that has happened 4 to 6 clock hours is a very significant dialysis, where if you lose additional iris, that can compromise the quality of vision, not vision to be precise, but quality of vision definitely it will compromise.
So I had one more question.
My thoughts on this is what made it more difficult was the already existing adherent glaucoma. And obviously the iris was not of normal architecture. So every time, sometimes we do have to think out of the box and reinvent ourselves on the table. That's fine.
No, probably adherent glaucoma made it easy, Devi, because
no, but the iris structure, architecture,
inside of the cornea,
might have been,
that's why it is not prolapsing that much.
That much outside, yeah. That also is part of it. The other thing is once the AC is formed and the globe is a little bit more tight, maybe you can use the AC maintainer also to keep it more formed. And of late, we have seen there have been videos of how the ACM entry itself is being used to reconstruct the pupil. So that can work two ways. It's not very easy actually talking from here. But the other one thing I would like to highlight here is more than any other case, a trauma repair needs more chair time before the surgery because the patient has to be counseled about so many things. And it's always worthwhile telling the patient that he might need more than one surgery, whatever be the kind of trauma. Even if it looks like a small needle stick injury, it's a trauma. So that's very important. More than any other case, a trauma needs more counseling before surgery. So that's one thing I would like to highlight. Dr. Manoranjan, I'm not coming to you right now. Dr. Bhaskar, any thoughts on this?
So just to reiterate, using a sharp MVR or a side port knife would have enabled you to make an entry from the opposite side to kind of push it down one. Second, yes, the surgery was excellently done by doing an iridodialysis, but in a phakic eye, unless you are experienced enough, you will end up causing more trauma to the crystalline lens, which as long as the anterior capsule is not breached, you have to be absolutely certain that you will not create a problem with that. Second, you are lucky that the remaining cornea in the area of your iridodialysis was clear for you to be able to do the iridodialysis repair. If there was a lot of edema in that area, you would not be able to attempt it. Probably what I would have done would have been just repair the thing. I would have left the iridodialysis because there is already a bit of phacodonosis. There is a bit of cataract. You will anyway need to take the patient up for a cataract surgery. Doing a pupillary repair at that point of a time becomes a lot more easier and controlled because you're not worried about touching the crystalline lens. At least as far as beginners are concerned and youngsters are concerned, that gives them the scope to not have more complications coming into their view. As far as using the incision for for injecting viscoelastic, the corneal incision, we would probably want to avoid it as much because that's an area which is edematous. So even if you feel that things are going in, it is very easy for the DM to get detached at that area because of the corneal edema that will be there. Third thing is when you have adherent glaucoma, and if you're going to be releasing the synechiae, this is not in this particular case. This case, you have already released the synechiae, you formed a pupilloplasty. So in a way, it is good because when you have the iris which is pulling the cornea, it actually causes a distortion of your corneal shape. Once that pull is released, the cornea can rebound back. So you might actually get a change in the curvature of the cornea once your broad-based synechiae is released. So in your case, since you have released it, it's a lot easier to calculate the lens power because you can use the topographic value over your reconstructed pupil to get your IOL calculation. If you had not done, then again, when you release it, you will end up having issues with respect to the IOL calculation. So if you have a broad-based PAS, if it is not coming in the way of your cataract surgery and you're doing a cataract surgery, you don't touch it, just do the cataract surgery and come out. If you have it and you have to release it, counsel the patient that there could be a surprise with respect to your IOL calculation because you're already having a scarred cornea, you're already having distorted case. In addition, you are going to be doing something which will cause a rebound increase in steepness of the cornea because the effect of the peripheral synechiae is released. So those would be another things that you would want to counsel the patient whenever you take the patient up for a cataract surgery. In your case, since you had addressed that, your cornea is a lot more clearer. with respect to your pupil being in the central area of your cornea, your peripheral synechiae having been released. So it becomes a lot easier.
So one more question I have for the expert.
I want to have one comment. Yeah. Shweta, continue, then I will ask you.
Oh, okay, sir. So in this case, I could see the pupil. There would be some cases where pupil is not there and completely adhere to the corneal opacity. So what are the options how we can create the pupil in such cases?
You would probably just wait, because when there's so much of edema, you will not be able to see the pupil sometimes. You just form the chamber, come back, you win the battle. You can win the war. I mean, you lose the war, you can win the battle tomorrow once the inflammation comes down. Because in day 2, day 3, by the time the corneal edema clears, your view, everything becomes better. The other thing would be, if you had a ruptured lens capsule, you would have had to do a cataract surgery also. This case did not have a ruptured lens capsule, so that was the saving grace. Otherwise, it would have, you had an incision inferiorly, but it would have been a lot difficult to get the nucleus out from that. You'll have to make a separate incision superiorly to kind of get the nucleus out in that case. That would have made it more challenging, because you would have one incision inferior, one incision superiorly.
I have a question. Shweta, how did you make sure that the lens was not broken? Because you're not able to see the pupil. Pupil is almost covering the lens area. That's one. Second thing, because you have fortunate the patient reported to you within 4 hours. Many times the patient reports after more than 24 hours, because from the rural area, they come to us after 24 hours. So how do you manage in a 24 hours case?
So your first question is that how I made sure the anterior capsule was not ruptured. So actually it was an intraoperative finding, because after the iododialysis, whole lens was covered. So when I saw the patient under microscope, the area of the iododialysis, I could see the glow. So there I was sure that everything is fine. The capsule is not ruptured. In fact, Raj has mentioned query phacodonesis and query cataract. So till that point of time, I was not sure whether cataract is there or not, because there was no view of the lens. So it was intraoperative. Actually, I could see that the lens capsule is intact. That's why I was much more vigilant while passing the Prolian suture for the iodinalysis repair. And the second question, sir, if it is like 24-hour injury, then we have to actually see the iris for the signs of viability. Sometimes it is not viable, we have to excise the iris, not even excise. So it's the duration and the clinical appearance of the iris which determines we have to do the abscission or not. That too also before 24 hours.
Yeah, thank you. That's any medical legal aspect you have to consider in these cases, because the patient straight came to the OT and we're not very sure about the medical legal aspects. So we have to think about the medical legal aspect also, because it's a trauma.
Yes, sir. Yes, sir. That's why I said the pre-operative chat time is so very important, and more so in these cases, because every case is a potential medical legal case. So I think we can now move to the second case. No.
Ma'am, just last question.
Yeah. Yeah, okay,
so
last
basically,
question.
Everybody has seen this video. This patient is going to go for the cataract surgery. So what do you think? SIC is phaco through the anterior root or through the posterior root pars vena? Because now the anterior chamber depth is very shallow. It was already shallow on table, and after intumescent cataract, it's further become shallow. I'm going to use iris hooks and a lot of manipulation, risk of DMD. So any special just 2-3 points before I go for this cataract surgery in this case?
So I would probably want you to get a UBM done to check the zonular status. So if the zonules are already lax or this thing, then it becomes easier. Yeah, if it's a young patient, just do a lensectomy, SFIOL kind of a thing. Because if your zonules are lax and you have to again suture it in the visibility domain, it will make it a lot more challenging to put your CTRs or CTS and suture it. Again, it's an eye which has a cornea which is already having an opacity. Now it has had a trauma, and you're going to be doing the third surgery. So the risk of corneal decompensation subsequently and requiring a corneal transplant subsequently has to be spoken to the patient. If your IOL calculation, you're going to be using the topographic value of your cornea, and that is, say, bizarre. It's either say 56, 60, or it is 44, or it is 37, 38. Then if at all you're going to be doing a PK, you might actually have to do an IOL exchange at that point of time. So these would be things that you would probably want to at least document in the file, if not discuss with the patient, because you need to be absolutely clear 5 years down the line, if the patient requires a corneal transplant, what is it that you're going to do with the lens, especially if you are sutured the lens.
Shweta, what is the reason for adherent glaucoma?
So the patient was giving history of xanthomatous fever in childhood, so probably viral fever, which has led to these corneal opacities in both the eyes. Which is
but another thing which you need to consider.
Keratomalacia. Yeah, so let's, Dr. Sakshi, if you're ready, maybe have your presentation. Please start sharing.
Yeah, as Sakshi shares a presentation, it was a good discussion regarding all the controversies. What we are going to present is not the management, but something which is awareness kind of thing. It's carbide gun,
Srikant is speaking.
epidemic rise. Yeah, which took a rise up in the COVID with web taking a front seat. So people learned how to make a carbide gun, but they could not learn how to make it properly. So the injuries have increased over the years. This is what I am seeing. Probably most of us have seen, but not noted. That is why this awareness presentation. Over to Sakshi.
Good evening. Are my slides visible and am I audible?
Yes. Go ahead.
Yes. We are not seeing your
So
video.
I'm going to present.
Our
We are
network
not
is little
seeing.
poor as usual. Yeah. We have heard that's enough. That's all. We'll be here.
You are not seen.
So good
You don't
evening.
know who
I'll
is
be
that.
starting. Yeah. So very sorry for the inconvenience, sir. There appears to be some network issue here. I'll go forward.
Yeah, please go ahead. Go ahead.
Okay, so in this session, I'll be highlighting about calcium carbide injuries, which is lesser known, but it is highly perilous. And coming on to the origin, calcium carbide's history dates back several years. When it reacts with water, it releases acetylene gas and generates significant heat, often accompanied by a loud explosion. Interestingly, this acetylene gas was initially employed for the purpose of fruit ripening. The loud explosion was utilized to deter animals from entering fields. So, in essence, the initial use of calcium carbide was primarily centered around agriculture. Amidst COVID lockdown and amidst efforts to curb pollution, which involved a ban on conventional firecrackers, there was a noticeable quick uptick in the usage of homemade and budget friendly fireworks. So, this situation prompted a surge in the popularity of carbide guns. Most incidents occurred while the users peeped into the gun from the muzzle side to find the cause of delayed explosion. The occurrence of calcium carbide related injuries dates back 2013 and was first documented by Bandyopadhyay et al. In 2013. Subsequently, Kabara et al. Reported similar injuries in 2020, further highlighting the ongoing concern about the carbide related ocular harm. Following these initial reports, our team at LV Prasad Eye Institute in Bhubaneswar was the first to report 16 cases of such injuries in international literature. This significant contribution served to increase awareness and understanding of this particular subject matter. The superior cornea was characteristically involved in 9 out of 16 of our cases. Patients presented with grade 5 or 6 ocular burns ultimately developed severe limbal stem cell deficiency (LSCD) during their follow-up period. So, continuing our investigation, what we did was divided all the cases into Group A and Group B. The Group A included Dua's grade 1 to 3 chemical injury, and Group B included Dua's grade 4 to 6 chemical injuries. All of these cases were categorized based on the extent of injury severity. The acute phase was medically managed with or without amniotic membrane transplantation, and the chronic phase was managed with symblepharon release with conjunctival autografting with or without SLET. Severe ocular burns were all unilateral. The most common mode of injury while using guns as fireworks in Group A and using these guns in agricultural fields to scare animals in the more severe group. Majority of the cases with grade 4 to 6 injuries had a presenting visual acuity of less than 20 by 200. During the acute phase, patients were primarily treated using medical therapy, often coupled with amniotic membrane transplantation, while in the chronic phase for visual rehabilitation, processes such as SLET, symblepharon release, CAG were performed. 2 out of 16 eyes in Group A underwent Symblepharon release, and in group B, 2 out of 13 eyes with total LSCD underwent SLET alone. A combined PK with SLET was done for one patient with a total corneal scar and a 360-degree LSCD. The median final BCVA was significantly higher in group A as compared to group B, with 21 out of 31 eyes achieving a median BCVA of more than 20/40 at the last follow-up, while 7 out of 13 eyes in group B had a best corrected visual acuity of less than 20/200 at the last follow-up. LSCD of less than 3 clock hours was seen in 6 eyes in group A, and in group B, 5 out of 13 eyes developed LSCD of more than 6 clock hours and 2 eyes went into phthisis bulbi. Now here is a further illustration of the sequelae of carbide injuries. In the first case, we can see that ultimately with post-AMG, the cornea ultimately healed with a nebular scar. In the second case, despite an AMG being done in the acute phase, the cornea healed with a superior corneal scar, a partial LSCD, and a superior symblepharon. While in the third case, the patient was planned for symblepharon release with a conjunctival autografting, and a stable ocular surface was noted at 15 months. And here is a table summarizing the outcomes of SLET in patients with carbide injuries. So the indication of SLET was mainly total LSCD secondary to grade 5 or 6 ocular burns. And we can appreciate that the visual acuity improved from counting finger 1 meter or counting finger close to face to 20/160 to 20/400 after 5 weeks to 3 months post-SLET. This picture here depicts our outcome of SLET. In this case, a persistent epithelial defect was noted 2 months post-injury. An epithelialized cornea was noted and the patient recovered with a visual acuity of 20/160. So to conclude, young males are mostly affected by ocular chemical injuries caused by these carbide guns. It can cause unilateral corneal blindness secondary to LSCD. Loss of vision in this age group leads to loss of economic productivity both for the family and the nation. Healthcare policies and legislation need to be enacted in order to discourage the use of these guns. That is all from my side. Thank you.
That was a nice presentation. Dr. Manoranjan, coming to you. Any words on this? Do you get such injuries in your practice?
Yeah, definitely not like we don't get this carbide guns, but we definitely it's a part of the alkali injury. I think depending upon the duration of presentation, depending on the quadrants of cornea totally involved, and depending on the time of presentation, the outcome matters. And I think it's properly managed, and most of the cases is the whatever the ABC pictures I saw, it is almost like half of the cornea or 60% of the cornea is involved, and so we could escape, and the visual outcome is not drastically bad. Sometimes this alkali injury, when it comes with a little bit late, and the concentration of the carbide in whatever use is more important. If it penetrates in the full thickness, or how much is the thickness, the deeper the penetration, what's that, and more is the more amount of LCD is there, then what is the prognosis? This appears to be very, what you call, very nice prognosis in terms of presentation and management. But this is the right thing. Only thing is that you should know when to do this SLET, and it is unilateral. You are lucky enough to have other eye for the SLET. If it is bilateral, then it is really a difficult, challenging thing for you to decide whether to take a PK. It's a bad case to take a PK, or whether to do a primary capro. It is on the hands of again you have to evaluate the posterior segment, glaucoma, everything before taking all the decision. So we are lucky here that other eye is saved, and we got one eye to manage well. So I think it's managed well. This is what we could have done for one eye injury, and or both eye asymmetrically injured or sustained injury, and one eye is there to spare. So that's what it should be done. And I think the time duration, Bhaskar can tell everyone when to intervene. Actually, ocular surface is already compromised due to this type of highly alkali burns. So the time of initial engine management is done already with the AMG and all. The next when you intervene for SLET,
Subsequent management.
Yeah, subsequent one, that's more important, point one. And suppose it is bilaterally it is involved, the when and you choose for allogenic graft, slet, and which type of allogenic, suppose you take allogenic graft, then which I will decide in bilateral case, and then how your allogenic graft will manage. Because most of the time Malaysian graft management is also very difficult. We have to think in a perspective that if both eyes are involved, then how do you manage? If one eye, then we have got something to do.
Before coming to Dr. Bhaskar, because he does a lot of this.
Dr. Devi, Dr. Devi, just a quick comment. There are two things. One, this is not only a chemical injury. It's an injury of chemical injury, thermal injury because the temperature is very high, and a mechanical injury because the forces of line particle are very, so it's a blast injury. So it's a the why we are trying for it is a blast injury with thermal, chemical, and mechanical kind of things. So, and they think what Dr. Manan said, why it is one unilateral more? Because they try to pin whether it is bust or the residual things. So luckily, most of the patients were one-eyed, one eye injury, and the right eye because most of them were right-handed, tipping the nozzle of the gun.
So before going to Dr. Bhaskar on this, I'll ask Dr. Vidisha because she's working in a setup where mostly we are solo corneal surgeons, and sometimes access to AMG is also not always there. So Dr. Vidisha, suppose you would see such a case, like what are the options in hand for you?
From
This
AMG,
works
we
for
can
most people. Yeah.
at least we can get a conjunctival autograft done for such cases if we are not having AMG, and otherwise we can get AMG and plan likewise, ma'am.
Conjunctival autograft from the other eye?
No, from if it is in less severe form, then we can get it from the other quadrant also. If not, then we can take AMG also, ma'am. AMG is available, like we can get it.
Autograft maybe wouldn't work as well. So I think the first thing is the primary treatment that each one of us can give, like the basics of management of any chemical injury and a blast injury. And more important is to recognize that there is LSCD or there is a limbal ischemia. And then if you have access to AMG, fine. If you don't have access to AMG, it's better to refer the patient somewhere where the AMG can be done rather than delaying on the case. I think this primary information has to go out to all practitioners because sometimes a delay can do a lot of damage.
No, Devi, is AMG not available commercially there? AMG
No,
is
it is available.
now
That is what I asked. Somebody who's practicing solo may not always have access to AMG. How does it work? Like, how does the
It is
system
commercially
work?
available. They can buy.
It's
It is
commercially
available. Dry AMG is also available.
If
Though I
it's
don't
not
think it works
available,
that
then
well.
we should
Then we can do all
refer
this.
actually. But we can at least start the initial treatment, whatever is there with us. At least the drops, like mostly we see that people are very skeptical about starting steroids, whether we should start or not. So we can at least give a thorough wash. We can start at least steroids for the patient. If we see that patient is not willing to go somewhere, or maybe that patient may delay, at least something we can do for the patient instead of just leaving it. We leave it advised and leave the patient.
Srikanth, you said blast injury is involved in this. How many of your cases had blast injury out of total denominator?
All of them, sir. All of them were
All of them, there were 3 or 4
No.
who did not have the blast injury.
There must be some rupture or something, penetration that has happened.
No, not necessarily
not
because the blast.
It's only a distant blast, and then only the material has come and stuck to the corneal surface.
It is that blast which comes and pressure and stays on the cornea.
I understand that. But
only
unless
2 of
there
them
is a deep penetration injury, it really will not cause so much harm.
No.
So it will. There will be a thermal injury also. There will be a thermal injury also, sir.
There are 3 parts to it.
Okay. Yeah. Proceed with the rest of the discussion.
Now, Dr. Bhaskar, back to you. So, like, what would be the timing of going for SLET? Any secondary, primarily yes, AMG, secondary, and also AMG, which are the cases we are to do AMG? Is it like AMG do in all cases, even if you don't see a limbal ischemia, visible limbal ischemia? And then AMG to SLET, then SLET to it's failing and it's not working, then what next? What should be the time interval? You're not audible. Please unmute yourself.
So I would divide it into two parts. One would be the treatment for the acute chemical burn, because this is basically similar to an acute alkali burn. And the next would be in terms of chronic visual rehabilitation. So there is a difference. In the acute burn, the most important part at this point of time is, for want of anything else, would be to at least grade it correctly with respect to duas. We have published our grading where we have looked at other parameters also, because when you are looking at a burn, dua does what dua basically takes into account is the amount of conjunctival defect and the amount whether the limbus is involved or not. He doesn't speak of ischemia because clinically in the acute stage, when there is a lot of chemosis, it is very difficult for you to assess limbal ischemia. And that depends on how deep the chemical has percolated, because your stem cells are sitting at a slightly deeper level and they are protected. So what he talks about is limbal involvement. So we basically are looking at defect around the limbus. We are looking at amount of conjunctival defect. Why we are looking at both these parameters in Dua's classification is, if the limbus is not functioning to epithelize the cornea which has got affected, at least the conjunctiva should come and cover. So if your conjunctiva is also significantly damaged, then it is going to take a longer time for the surface to epithelize. The first thing that we need to achieve in a chemical burn is epithelization of the surface. So we have published our report where we said that anything which is more than grade 4 or grade 5, based on Dua's classification, you might want to surgically intervene. Now you can choose between doing an amniotic as the first instance and say that, okay, let me see how it responds. If it is not healing as well, then you might then go ahead and take the next step of using allogenic slet to epithelization. That is different from using slet for vision. The idea in the acute chemical injury is to just epithelize the surface. When you are addressing it surgically, you also have to look at whether there is scleral ischemia. Scleral ischemia will be seen like a blanching, and when you cut the tissues intra-op, it will not bleed. Normally, when you cut the tenons and you cut the episcleral tissue, it should bleed, indicating vitality. When you're cutting it and it is not bleeding, it indicates a lack of vasculature, which basically means it is not healthy. So you will have to dissect and remove. Just like for a burns patient's skin, they debride necrotic tissue, allowing a healthy granulation tissue to form. Similarly, if there is scleral ischemia, you will have to remove the dead devitalized tissue. You will need to mobilize healthy tenons from the fornix, mobilize it closer to the limbus and secure it. You will need to check how the intraocular pressure is, because the pressure might be high, the pressure might be low. You will have particles which are stuck there. If the particles are more superficial, you can use EDTA to chelate the particles. If you will have to take the patient up into the OR, because sometimes if it is a child, in terms of a lime, it will be stuck into the fornix. You will have to double evert the fornix to remove the lime plaque. In these patients, in the acute stage, you have a lime plaque sitting there. You will have to surgically intervene to remove the lime plaque, because it is still not got completely converted to calcium carbonate, where it becomes inert. Till it gets completely converted, it is going to keep leaching the chemical. Your pH is going to keep on being high. You will not be able to get your surface to epithelize in the eye to quiet. So the acute injury, you're looking at establishing epithelization, establishing vascularization. So if there is a scleral ischemia, you're going to be doing a tenonplasty. If there is foreign particles which are stuck, you're going to be washing it or surgically removing it. If the severity is more than grade 5 or 6 duas, we would normally advise doing an allogenic slet to epithelize the surface. The reason is, if 80%, 70% or 80% of conjunctiva is deepithelized, the time it takes for the entire surface to epithelize, your cornea will either end up getting scarred or you will end up with a perforation. So from a general ophthalmologist point of view, if you're seeing worse than grade 4, you have to surgically intervene. Either you can do it yourself or you refer it to a higher center where the necessary treatment will be done. Coming to the use of conjunctival graft in the acute phase, we are not taking any tissue from the healthy eye. The healthy eye will be touched only in the chronic phase when you visually rehabilitate them, because these are precious cells, precious tissue. You don't want to be touching them 10 times. So the acute phase, you're basically going to be doing an amniotic, but again, it's not that one amniotic you do and it is over. You have to keep following them up for the surface to epithelium. Your job is not done till the surface epithelializes. You're not worried about a clear cornea in such severe cases at the beginning. You just want an epithelium. It could be conjunctiva. It is absolutely fine. As long as you get an epithelium, underlying cornea is clear, you have won the battle, you can fight the war subsequently. Once
Oscar, how do you check whether epithelialization has happened or not?
Fluorescein stain.
No, that what?
No,
it's not for me, it's for the audience.
Fluorescein stain, you will use topical steroids. One of the speakers said, has to be started in chemical injury. The treatment, there is significant inflammation, you have to start steroids. But you will monitor. And once you are crossing 10 days, 2 weeks, people are worried that steroids will cause stromal melt. Yes, steroids can cause stromal melt. That is why if the defect is more than 10 days, you intervene. You have to go and do an amniotic. You have to put something to allow the inflammation to settle down and to allow the epithelium to grow. Again, the timing of intervention also depends when the patient presents to you. Patient presents immediately, you still have maybe about a week to see how it responds to medical management. If the patient has presented 2 weeks later, that means, and the surface is still deepithelialized and there is a large area which is defective, that means he started off with a much worse grade of injury. What you are seeing today is a grade 4, would have probably been a grade 6 at presentation. You've already lost 2 weeks of time. Your intervention has to be faster. Your intervention will be done as many times as required to make sure the eye is safe. And the eye will be safe only if the surface epithelializes. So you will, if you can't get alloslet, you don't want to do alloslet, then you do an amniotic, you do a tarsorrhaphy, leave a small probable chink for you to keep assessing. But then if you don't do a slit and the entire lids will get stuck to the cornea, then subsequent visual rehabilitation becomes a lot more challenging.
Dr. Bhaskar, one question.
Yeah.
Instead of doing alloslet for these grade 5, 6 injuries, what is your opinion about SOMET? This simple oral mucosal epithelial transplant?
Doesn't work as well. Mucosa still needs a little bit of vascularity as compared to the limbal cells. Your corneal cells epithelium doesn't need as much vascularity. So, I mean, way back 2007, actually, we had just done a couple of cases. We did not label it as SOMET at that point of time because we did not think that this was something which was so intuitive. Dr. Vinay only had done it. We had done it for a case. So for the mucosa, the problem is it also needs a little bit of vascularity. Yes, if you don't have allogenic cells and you want to put some mucosa, you basically want some epithelium. So initially, before the concept of slit came, what we were trying was to just take a strip of mucosa and try to cover the cornea, because you want the cornea to get protected. Because if your cornea is protected, a subsequent visual rehabilitation becomes a lot more easier. The moment you end up with a scarred cornea requiring an LK, requiring a PK, your visual outcome, your success of slit, your success of any stem cell-based therapy becomes lesser. So the idea is to get the epithelium on as early as possible, and even a therapeutic grade cornea is fine, because what you want is only limbal cells. Even an 80-year-old tissue is fine. It will survive for the 2 weeks to get the surface to epithelialize. Once it epithelializes, then you can take a break, 6 months, follow the patient up for pressure, follow the patient up for symblepharon formation. 6 to 8 months later, you can plan a procedure. Again, when you are planning a procedure, you will get an ASOCT done to check the underlying corneal thickness, because you need to decide whether you would want to combine it with a corneal procedure or you would want to stage it. Then you can do a slit if it is a unilateral injury. If it is a bilateral injury, then depending on how moist the eye is, how good the blink is, you will take a call on whether you want to go down the allogenic limbal stem cell based therapy versus a keratoprosthesis. We would probably think we might still give a chance of allogenic limbal stem cell based therapy under immunosuppression. Here, when you're doing it from a vision point of view, you will put the patient on systemic immunosuppression, which will ideally be all three. It would be cyclosporine or tacrolimus, mycophenolate, and systemic steroids, just like how people treat a renal transplant. We become a little bit selective when we give medicines, because we are not used to giving these medications ourselves. So if you are not used to it, take the help of your nephrologist. They are very comfortable and very happy to give these medications. If you're doing an allogenic slit, you're doing an allogenic limbal stem cell transplant, you're doing a high-risk graft, you have to hit the immunosuppression to the maximum that is required. If a renal transplant with so much of vascularity can reasonably well survive, it's only the question of us not using adequate immunosuppression that prevents our grafts from surviving in these challenging cases. So if you feel it is not worth or the patient cannot afford systemic immunosuppression, then the option would be for keratoprosthesis, which would depend on how good the blink is, how moist the eye is. That will decide and whether you would want to do a Boston type 1 or you would want to go ahead and do a type 2 keratoprosthesis, which could either be a Boston type 2 or the OKP. So there is a step ladder to the approach. But what I would want all postgraduates who are attending to understand is one amniotic membrane for a chemical injury doesn't mean job is done. You have to keep following up the patient till you see no defect on the surface. And anytime you start seeing a cornea melting, your escalation ladder has to be faster. That means you have not been prompt enough to note when the cornea started melting. So your follow-ups are going to be every third day or fourth day. It's not going to be 2 weeks down the line.
Yeah, this is only acute management of acute alkali burn.
Yes.
There is again chronic burn and adhesions.
Yes.
You should avoid.
Yes.
Intraocular pressure management is another aspect which we need to see. The collagen breakdown should be avoided. All this, because it becomes a long essay, which I think the time is very short, and probably Devi will move on to the next aspect.
One final word from Dr. Jayashree, because she works in a tertiary government setup. So Dr. Jayashree Dora ma'am, if she's there.
Madam is there? Yeah, she's there. But yeah.
Yeah, she's there. She unmuted her. Yes, madam. So like,
we want to see you
what would be your approach, madam? Since you are working in a different kind of setup, like it's a tertiary and a government setup, so you would be seeing such cases in a much later stage, in a delayed stage. So like, I would like to have your thoughts on this.
Sometimes in delayed stage also we are seeing cases, and in delayed case I have tried amniotic membrane graft along with symblepharon release and mucous membrane graft on the lid margin and amniotic membrane graft. Not more cases, 1 or 2 cases I had done that, and it is given a very good result in that, in chronic cases.
So we should not give up on these cases. So that is the message. I mean, so even if it's very late, we must give them some chance.
If I could just add a point.
Yeah.
Yes.
Yeah. Especially if it's a bilateral injury, as long as the perception of light is there, you will fight. Yes. Most of these are young patients. You will fight as long as they give up and they say we cannot. If they cannot afford maybe a government hospital or whatever, but it's worth every penny, because if you can save the globe with keratoprosthesis, at least to the extent of them taking care of their daily basic needs, you will be able to make them and their family a lot happier.
Most of these cases, posterior segment will be all right. So
it will get worse with glaucoma. It will get worse with glaucoma as it gets.
Yeah, if you are neglecting glaucoma in the early phases.
Yes. So that's why we only look at defect. We don't look at the other things which come in chemical injury.
That's
so all those things are also important. And the other thing is in that paper, the only other thing that I would have wanted was the time duration that it took for the acute phase to settle down. How long did it take for the acute cases to settle down? And that also would have been a parameter which would have been different between the grade 1 to 3 and the grade 5 and 6. And that would probably have been the reason why the grade 5 and 6 also ended up having
prognosis.
Yes, poorer prognosis.
A worse prognosis. Dr. Manoranjan, so now to your series, and Dr. Sharmishta, please 15-20 minutes bonus for us.
Okay, fine.
Thank
you,
you,
Dr. Manoranjan, please.
Thank you so much. So now it is 9 o'clock. So let us.
No problem here. We should learn.
It's okay. Please start sharing.
Definitely.
So already we have dealt with the main corneal injuries to start with. So my topic given to me is only sclerocorneal tears. So I feel that okay, am I audible?
Yeah, you're audible.
Is it full screen now? Now it is okay?
Now.
Okay. So my topic is today surgical management of sclerocorneal tears. Basically, I have got some 6-7 videos and which I could manage to get it in this 2 weeks time, 10 days time. So I just go through the basics of these slides and then we'll go to the surgery per se. So I don't have any financial interest, but as we have discussed, the goals of the corneal tear or sclerocorneal tears are to prevent further injury. We have to triage and then treat the associated injury, we usually forget, and then expedite the post-operative evaluation and anesthesia clearance for earlier or faster intervention. We need to control the infection by giving systemic and topical antibiotics. Need to have a good medical documentation, and also we have to have an honest, frank discussion with the patient and family members before touching the patients. So requisite as usual, we'll go for X-ray, B scan, CT scan, or others like selection of cases for general anesthesia. And after that, we need to go for basic things is pad and bandage with topical antibiotics and painkiller or anti-emetic. Start oral antibiotics or IV antibiotics before going for this surgery per se. And don't use topical aggressive antibiotics like hourly antibiotics is not needed. So as usual, X-ray, you can find a foreign body, which I am seeing showing you here. It is more important to rule out other abdominal fractures, associated fractures also, and it is most important for medical legal aspect. So ultrasound also, wherever it is, time is there, it is a must because it rules out vitreous hemorrhage, detachment, choroidal detachment, intraocular foreign bodies, or early onset endophthalmitis. CT, of course, better for perforated globes and all, and it is also will take out the orbital fractures and metallic foreign body. So surgical goal is the main important thing is restoration of anatomically and anatomy, and then watertight compartment. If you achieve it is good, and restoration of optimal visual function and prevent future complications like endophthalmitis or sympathetic ophthalmia. So principle in the first is suture placement. We need to have a suture which is nylon sutures, and suture tip and the suture holder, it should be held perpendicular to the corneal surface. 90% depth is allowed. 1 to 2 millimeter depth, size of the sutures, and it should start from the healthy end of the tear. And also the pattern is certain. If it is involving visual axis, minimal length in the center and larger length of sutures in the periphery. So this is how we generally, this is a golden standard rule. We have been following it. All of us, we know, and wherever we work, one is the zone 1, zone 2, and zone 3 beyond the 5 millimeter. So this is how you can get all type of injuries depending upon the zone. So clear zone also, you can see corneal, lacerated, zigzags, stellate, and also next, if you come to the limbus, you can have any permutation combinations. So this is the ideal way of holding the needle at the 2/3 and 1/3 junction. And next is the anatomical landmarks, which gives us a easy access or approximation will be much better. And then these are all the angles of the injury, either the vascularization of the cornea or then the stellate edge and then limbus. These are all the anatomical aspects. When you oppose, you have to look for this and oppose well. So next is the placement of suture. Ideally, this should be like this, 90% depth, equidistant. If it is anyway shallow, it will have internal gap. If it is very deep, it will follow the track of bacterial or infective on this thing. And if it is irregular, then it can have a inner lip overlay or the outer lip, which will suit outside. So this is the case for a ideal suturing in case of a lacerated injury. So A and F are the ideal suturing techniques, and these are all these things which can happen to us while learning phase. So this is how the Roseways technique of suturing from center to periphery. And the first video will start now. This is the video which I had just, this is an old video actually, or 3-4 years back. I didn't get this type of case in this 15 days time. So this is the video which is showing a clear corneal injury along with this scleral injury. This was a soda bottle injury where the patient had turned up immediately to us. So after doing all the necessary investigation, we started doing the suturing. And once you touch that exposed iris, which is beyond the ora serrata, now you see the bleeding. It just shifts into the AC. So you have to take little bit extra time and with the help of viscoelastic, you have to dislodge the clot formation, and slowly you can find that whole clot will come out. And once that clot is come out, then you put air bubble, suture the scleral and corneal wounds and bury it accordingly. Next is the laceration injury, which involves the visual axis. The no-touch technique is the golden standard, or minimal tissue handling is the golden standard in during this type of injuries. This is the second case, which is freshly done just
Dr.
15 days
Manranjan,
back.
if I might interrupt for 1 minute. I
Yeah.
think the beautiful thing about the other video that you showed just now was the first suture is at the limbus. I think that is one very pertinent point there.
Yeah.
You have put it there, but I think you didn't mention.
Okay. So the second, you can see, and these are all like different this thing. This I have done a side port and then did a suture, and the question will arise. You don't know what is there underneath. So once you put the topical anti-dilating drops, and then you see that glue to use the extent. Now you can see the PCR there. So these are all difficult cases. Suddenly you see a PCR. So I have done the vitrectomy there and then started suturing. So this is how you can be, surprises will be there. Always keep it mind open. Always keep your vitrectomy probe ready, because this type of PC rent, we have to just negotiate the vitreator here only. You need not go so much down. We just do a vitrectomy just above the PC or at just below the iris, so that, and little bit on the under interface, so that you will get a clear interface. Then put a air bubble and then leave it like that for secondary IOL. This is the third case. You can see this is the third case presented to us with a cracker blast injury, and then because the cracker blast is there, the passerby was sitting and just seeing, watching the cracker blast. So the stone came and hit the eyes. Now how you can see the whole of the anterior segment is distorted mostly. So you can see the lens is dislocated from posterior chamber to anterior. So here you, this is the principle of suturing. You suture at the angle first. That's what I told you. Anatomical landmarks, it can is more important. You suture angle because it is open. Then you suture perpendicular to each tear. So this is how you start suturing one by one. And once the suture is complete, then you have to make a separate tunnel for the lens to be removed, and do a SICS tunnel and remove the cataract and leave it for secondary glaucoma. And this is also vitrectomy was there, vitrectomy was there because lens is come. So I have done a vitrectomy to form the AC and left it for the secondary IOL after 1 month's time. So next is, this is how, if you get a triangular form, how you need to go for a suturing. This is very simple. This is how, this is a case which was presented to us, and we may use this method of simple tear suturing with this type of, first you suture at this angle and then you suture at the base both, and then near the apex. This of 5 to 7 sutures here will do. But before that, we need to have a side port, separate the synechia, perform, dilate it well, and to see if there is intercapsular injury or not. If it is not injured, then you can proceed, and at the end use Pylomin to constrict the pupil. So this is how the management of stellate injury is very complex. Whatever said and done, I have seen stellate injury is a complex injury, not because of the injury size, but it is just the depth, irregular depth, and the floppy wound edges, and the tissue loss at the end of the wound. All these things. So I usually was doing first thing, but it was not very accurate with me. So I used to always get either over tight wound gap, or will be so loose that it will be pop up. So that is why I have shifted to all like this type of suturing. I prefer to do inverse triangle, 3 triangle, exactly 3 triangle. You can see here 3 triangles as the separation. Imagine this is a 3 triangle of separation is there. So I put 3 more triangle here of suturing. So it is, if you imagine this is a 3 triangle separate tier. This is a stellate tier. So there is a three triangle. So now when I place switches, I also make inverse to this. So it will be very well. Of course, put air bubble. No need to put glue. This thing. Put a BCL. Glue BCL. Most of the people do, but you do not know the extent of what do you call no laceration. It is there. Whether it will develop infection or infiltrate during the wound. So better not to do anything. Just to this suturing, put air bubble, and then put a pattern bandage and review it in subsequent days. You will see all this edema will subside. I feel cornea is very forgiving. So this is another technique where you suture as you glow down. That is what the corneoscleral suture is. The basic fundamental is this. You have to suture at the limbus first, then suture towards the sclera, then come back towards the cornea. So you can see this. This is the video. This is also within that. And many times you'll have many permutation combination. So there is no, what is called, no, there is no proper formula for it. So once you separate, and I was in, I have started the suturing with the limbus, this, and once this sclera is done, then you go to cornea and suture it as per this thing. And if it is ALC bridge is there, please aspirate the cortex, because you cannot leave it for intumescence, and you leave it like that for the secondary surgeries. So this is how the second same thing. This is one more of this video which says, you can see here, there was a that is a different and here, and this is a different here. So there was a lens rupture there. So I removed the lens, the cataracted lens there. ALC bridge was there. Here there is no ALC bridge. So I'm just suturing it. And because it was prolapsed out, and you cannot, don't try to push it down because it may be infective. So let it be little bit irregular people at the periphery, doesn't matter. So you suture at the suture starts at the limbus, and then you go down as you proceed towards sclera. You make it clear and slowly proceed down. Once you are done with this posterior aspect, from anterior to posterior you go. Once you are done with these scleral switches, then you come back to cornea, and then you can form the AC. I'm just dilating the drops and just to see whether you can see the lens is clear here. Lens is not involved. So this is one more case. This type of different type of case of different scenarios. You can see here same sclerocorneal injuries with vitreous is popping out. So one vitreous is popping out. Once you cut the iris, so you take your automatic vitrectomy and vitrector you take, and then cut the prolapse iris as well as the vitreous. You need not do so much vitrectomy, but just to do vitrectomy to remove the vitreous knuckle for the, and we already have done a side port. Once the surgery is done, please separate and please separate those iris adhesions from the wound, and then you can put air bubble, because it most of the time it bleeds, because we have involved the limbus, sclera, and then the bleeding is quite common. So all these switches has to be buried. I have just cut it for interest of time, and so this is how management of uveal tissue. This is one more video. If you don't have, it is just sitting like that, you just can cut it and leave it like that, and you do not repose if it is beyond 24 hours. I feel unless it is within 24 hours, and you have to, as already Sweta has pointed out, so you see for the vitality, but most of the time, no, the vitality is just like relative. We do not know actually. They don't give proper history. It is better to take it out if it is more than 24 hours. Don't try to repose it back. While reposing, you will cause DM detachment. So you don't do that. You just, so post of care, as I said, anyhow, pad and bandage will be there for 6 hours. Then slit lamp assessment, you have to see for the suture integrity, AC formation, and content in the AC, like see for the hypema or lens matter, vitreous. So these are all the things we have to see. Systemic antibiotic, analgesics has to be there. Topical steroids and cycloplegics with the topical anti-glaucoma medications as per need, as per case to case. This is not like in gold standard for every case. You have to see the wound, you have to see the surrounding infiltrate, you have to see the injury, you have to see the time of presentation, you have to see the job the patient is doing, and you have to see in the time of presentation, and also most important, you have to see, you have to rule out the alleged injury, that is medical legal aspect. Sometimes, we had a long time back in Tamil Nadu, we had a case where scale injury was a steel scale was thrown to the student by a teacher, and it went for a big case here. So we had to, incidentally, I only went to did the repair, and I had to go for court. Many times you say that it is not child's fault. So that is how you can land up in any problem. They will come crying, but when you've done with and doing all this pre-op counseling also, men land up you to see any court many times. So that is how we can manage the main management principle for post-op is to prevent infection, the suppression of the inflammation, and controlling IOP and relieving pain. So most probably, if they are really sclerocorneal injury, you can start oral or systemic antibiotics with cycloplegics and steroid. And post-operative endophthalmitis is a primary concern for all cases of who have got this open globe or penetrating injuries. So you see, what are the cases which are post or more risk factors with post-operative endophthalmitis? First, the dirtiness of the wound which is there, the retained intraocular foreign body, the setting which from which background they have come, whether they are in a rural background or in a farming doing or in a vegetable marketing, vegetable market they are working, or they are a loadman in different setup, or they work in a factory with a marble factory, or in a steel lathe factory. So many things. The history actually clinch your diagnosis and help you to be alert or anticipate better than others. So wound repair delayed is always concerned, but it depend upon the 24 hours or less than 24 hours or more than 24 hours, will have a better outcome. So next is again delayed repair. These are all the increased risk factors for post-operative endophthalmitis. Delayed repair, dirty wound, anterior capsule rupture, or anything, vitreous disturbance, all these things has to be kept in mind. So thank you for the kind patience hearing, and I think I have just managed to finish, but it is already overshooted the time. Thank you for giving me the opportunity, Devi, and all the speakers and my teachers and my seniors. Thank you for involving me in this forum.
Thank you, Dr. Manranjan. That was like a didactic lecture for our postgraduates. I'm sure they will have benefited if they've listened and observed carefully. Coming to you, Dr. Swati. Yeah, I think Dr. Manranjan mentioned vancomycin, ceftazidime. So, like in your practice, what would be your antibiotic of choice for all cases of trauma?
Yeah, all cases of this thing, it depends on the amount. For me, it is okay. No, okay, that's for you. Okay.
Yeah.
Sorry.
So yeah, no, that's okay. So definitely, vancomycin and ceftazidime has been used very vividly and very widely, and I would say that that would cover the major spectrum. Also, a lot of times when you do not have an option to start immediately ceftazidime and vancomycin, I think a broad spectrum cephalosporin is also equally good to start initially, along with tobramycin. So that would also be a drug of choice. And obviously, when we are talking about infections, we need to be very sure that, we take the cultures and whatever possible and do the scrapings or take the vitreous samples and probably then send for microbiology and then depending on start the treatment.
I was talking about wound prophylaxis, like where it is not obviously infected, like any injury case or corneal trauma case, like what would be the antibiotic you would start on?
I would start with the third generation. Sorry. So I would start with the moxifloxacin and a tobramycin combination also. Systemic,
Systemic.
I think Dr. Ajit Babu would be would be the best person to tell us about the systemic regime, which penetrates, because we at LV Prasad were using ciprofloxacin 750 mg, and I don't know what is the scenario
I
right
do that.
now.
I do that.
Yeah.
Dr. Smriti, what is your protocol right now? Because I start them off with ciprofloxacin.
Yes.
Yeah, it's the same. Even now also we give ciprofloxacin in adults, and in children where cipro is not indicated, we give cefotaxime. So that is what we give. And topical post-operatively, we have moved behind and we have gone back to chloramphenicol now. Until unless it is like looks infected, and like you are doing a scraping and seeing some organisms which is sensitive to any specific any other medications. So post operatively it's it's sorry, no financial interest, but it is chloramphenicol. And depending on whether it is a fresh and what is the method, what is the mode of injury, whether to start steroids on day one or to wait, or sometimes we wait for even for 1 week to see if there is any infiltrate in the wound margin.
So Dr. Manoranjan, coming to you, was that like a prophylactic or was it like a treatment? The one you had mentioned, like as per protocol in your setup, in your organization, like what would be the treatment, starting antibiotic for prophylaxis, like when there's no visible infection? You're not audible. I think you have to unmute yourself.
Okay, thank you. Thank you. No, the very simple thing that if it is not at all infected like that, no, we still give a Cipro 750 for 5 days. And for adult and for all children, we give Flexin syrup. Or whichever is capsule for 500 milligrams, depends. The same for 5 days, BD for 5 days as a prophylaxis. Even if you take up for routine surgery, clean cut case, no wound, no penetration beyond the cornea, then also we give as a routine. Just like you give no tetanus prophylaxis for each case, or ultrasound.
But most of the antibiotics, Manoranjan, the penetration is very poor. So oral antibiotics are now not much preferred except for generation, that is moxifloxacin group. Okay, that can be given prophylactically.
Orally,
if
sir?
the wounds are dirty, then also there is no encourage for intraoperative intraocular antibiotic injection, because hypotony will be there and it is much more dangerous to give the antibiotics rather than not giving. Unless a good wound construction is there and the wounds are dirty, probably a combination of vancomycin and ceftazidime can be given. Other than this, probably you just close observation, and then only if the infection rises, then you need to manage that.
Just to add, sir, one point, we are giving this because when the medical legal case comes, they ask only one question, sir: have you started oral antibiotics? Question is like this.
I know. I understand that.
So what is working out, what is not working out is a different issue. But legal, if you go and start in the court, he will ask.
Legally also now the books we have rewritten, no, in AOS we have brought out the book so that you can claim that book as a reference.
But but sir, when this is a universal question. First question, have you started antibiotics, sir? That is the first question.
Yeah, you have started the antibiotic. Where topical.
So that's what I said very clearly.
You wanted legal protection, but if you are terrified, then what about a ophthalmologist who is sitting in the periphery?
That is how this government
gets worse for them to defend themselves.
Yeah, that's what I'm saying. So in the institute, we should give a good standard practice so that even the peripheral ophthalmologist sitting in the periphery can claim.
So what would you recommend? Suppose apparently clear-cut sclerocorneal injury comes and you are
clear sclerocorneal injury,
yes, apparently clear.
Clean wound.
Yes, sir, apparently
no
clear.
intraocular antibiotics are required.
No, sir, systemic. I'm talking about
Systemic, you can
systemic
give oral
prophylaxis.
moxie.
Cipro has a place?
Cipro has a little bit less penetration. That's why it is not recommended.
Sir, so for a standard practitioner, like for
You
ease of
can give
availability, we
intracameral
can start with
moxifloxacin
Cipro.
also.
Right. Intracameral moxifloxacin
Yeah, can be given.
We give in all
So just a
injuries,
little before
intracameral.
you said intracameral is not recommended even if it is
Intraocular.
infected.
Intraocular is like intravitreal injection.
Intravitreal. Yeah, I think that is
Okay.
what Dr.
Intracameral is and into the antechamber.
Intracameral is routine, sir.
Yeah.
Yeah. So
Okay.
maybe we can start off with Cipro
Yeah.
prophylactically for cases that even look clean at the first glance. And then as the case goes, then you can alter your antibiotics and change your antibiotics as per
Sir, do
sensitivity.
you use forbidden iodine during surgery preoperatively?
So in open
Forbidden
wound,
iodine
sir,
on the
no.
operative table.
Not in
No?
open, not in open wound, sir.
Painting can be, but not into the conjunctival sac.
Yeah. Yeah. Periocular, yes, sir. Not in the cul-de-sac.
Even before taking the patient for surgery, like how we do in other cataract surgery patients, cataract cases, here we should not use povidone iodine. Only after proper closure of the wound, maybe 1 or 2 drops.
Yes, of course.
You can,
Yes, yes, yes.
So that is one thing that is different. And yeah, any points, any?
Yeah, just one
Dr.
comment.
Hijab.
Just one comment for the postgraduates. That for suturing the corneoscleral tears, only interrupted sutures, no continuous suturing. And to allow the sutures to be in situ at least for 3 months unless they become loose earlier.
Yes.
I said I have got a point to. I have got a point.
Yes, sir, please. Yes,
So,
sir, please.
in our state now, there is a mustering of medical colleges. There were 13 medical colleges now opened up, and most of them in the rural areas, and manned by some assistant professors or assistant professors, I would say. There no proper HODs are like that. So in these circumstances, as the patient's particular status is full body, Kandamar, the patient cannot travel to Berhampur or Bhubaneswar for better treatment. So this has to be managed in the locally only. So we have to think about those doctors who because they don't have much experience in coming in the injuries in the medical colleges, in the training medical colleges, I would say. So those patients, I propose teleophthalmology. They should have some teleophthalmology so that they can be guided from headquarters, from the base hospitals like Bhubaneswar, Cuttack, or let us say Berhampur. So they can be, guided properly how to suture and how to follow up the patient. So this is my comment.
Yes, sir, definitely, sir. So the idea of these colleges is exactly that for cases that are emergency, they need not have to travel far. So the idea of developing them is exactly that for even of the littlest of reasons, they need not have to travel
The
far.
government is starting with a good
Teleophthalmology.
intention.
Yes, sir. Sometimes it is the primary surgery that decides a lot
Not
about the
only
future of the
teleophthalmology,
outcome of the eye.
Maybe
So the idea is
something.
that they should not lose time. Teleophthalmology, of course, yes, but nowadays I think even with our WhatsApp and so many methods of taking photographs, if somebody really wants to do it, that person can do it.
No, some team, maybe three members or 5-member team from OSOS can go for 3 days, observe them what they are doing, because everything is very green on WhatsApp and Facebook and your teleophthalmology, but practically they probably not. Let us be honest and truthful. Okay.
Sir, yes, sir. We
So
must
we
remember
should go and
that
say 3 days what they are doing and then probably give them support.
So one more thing, sir,
guidance
we
and
must remember that they have come out from our systems. So we have to start at the
Madam,
base there. So what have we
our
taught them at
system
our
is not
systems?
supporting
Why
us.
this need that 3 people have to go and teach them now, sir? What
Not
they could
teach,
learn
not
in 3
teach.
years.
Not teach. I'm not saying
So
teach.
whatever.
I'm
What we
saying
couldn't
observe
teach them in
and
3
suggest.
years.
observe and
Yes,
suggest
sir,
some
that will
modification.
yes, sir, that will definitely help. But we have to go now more basic. So if we
Only thing
can't
we
teach
need
them
to,
in 3 years,
yeah, no.
Go.
Only thing we need to learn
yeah,
is
yes,
not to
we
offend
have
any
to teach
system,
ourselves. Correct.
just modify so that it is a better system. That's it.
So Dakshata 2.0 is coming up.
Yes.
Yes, sir.
Zoom meeting and
So 2 or
workshops.
3 things that I feel must go out to the postgraduates because this is very important. A case of injury is not a lost eye. A lot can be done over there. So it is how well you do it at the primary first sitting is very important.
Yes.
And second thing is whether there are any medical legal issues or not, we must cover ourselves medical legally. Every patient is a potential medical legal case. So that aspect of injury, or for that matter, something like, like they're doing cataract, 10 cases in an hour, whatever it is, the medical legal aspect has to be ingrained in them. So they must take up that case. And secondly is if you cannot do any good, do not do any harm. So that thing is also there. So suppose you feel that you are not capable of managing a case, give the basic care, you are not wrong there, and refer the patient to a place or a person who can do better. So these are the 3 things. And I think they should not think of like, tum lo ye trauma repair karo. Because
No. Not only
sometimes
that,
you need
all
a
trauma
better
cases.
hand, you need better instruments for trauma repair. So it is not that they're done with the bad instruments, bad repair cases, chalo repair OT mein karo, bad microscope, bad instruments. The best hands and the best instruments must be given to these eyes.
And trauma requires a longer follow-up, and single time
Closer
management do
follow-up.
not work in trauma.
Follow-up. Again.
Yeah, just wanted to add thing one just for final comment. Like I feel like I think for trauma cases and all, we should promise less and deliver more.
Yes.
That is
life
how we
mein
can
hai
step
bhai.
ourselves.
Mano, it is for life also. You should never promise.
Yeah, yes, that is also universally applicable. Can be, yes, sir.
So Dr. Vidisha, are you there?
Vidisha is there. She's
she's
appearing
there.
and disappearing. I don't know why.
Yeah, your thoughts on this?
Ma'am, that is what we should not think that traumatized eye is already gone. Like usually PGs will think it's a trauma eye, so he won't get a vision. We have seen cases improving from PL to even 6/9 or 6/12. So we should always try to give our best. If we think that we are not capable of doing, then we should look for the person whom we think can give the best. And we should refer them at the earliest.
Hmm?
No, if we are not able to manage at one level, then
yeah.
refer them at the earliest.
That could
Yes.
No,
I thought you refer them immediately.
No.
No, sir, we are getting a lot of immediate referrals.
Yes.
Shunted.
No.
One is referring and one is shunting. So there's a difference between the two. So I think we should do more of try not to do any
I think
shunting.
on screen we should be a little bit careful in our words.
No, it's not that I can't do it. You should give your best and then refer.
Yes.
You should not just go. Idhar nahi hoga, go. Not like that.
Use the people around you and yourself to give the best management. That's what I would say.
Yes.
So can we conclude?
Thank you, sir. Yes.
मैंने
Thank you for the
हिजाब
extra
और
time.
स्वाति इतना लोग मेरा है ना हमारा कोलीग्स है एलवीपी में I'm seeing them happily.
Yeah, how are you, sir? Very happy to see you
Good.
after a long
Yeah,
time.
Happy to see you too. Happy to see you too.
Yeah.
So, sir, can we conclude now, sir?
Madam,
Yes,
आप
sir.
जो बोलेंगे वही करेंगे ना हम. You know that.
So I take this opportunity to thank all of you. Sincere thanks to the esteemed expert panel, Dr. Ajit Babu sir, Dr. Vidya, Dr. Hijab, Dr. Swati, Dr. Bhaskar, Dr. MRD, Dr. Shrikant, BNR sir, Dr. Smruti, Dr. Vidisha, Dr. Jayashree Dora ma'am, Dr. Shweta for sharing their invaluable expertise and insights. Special appreciation to Dr. Devi Aishwarya Das for her excellent moderation that kept the session engaging and informative throughout. And we are grateful to Dr. Srimanta Behera, our President OSOS, for his leadership and support in organizing this educational initiative. Thanks to the distinguished speakers, Dr. Raj, Dr. Sakshi, and Dr. MRD, for their enlightening presentations and enriching our understanding of corneal trauma management. Finally, we acknowledge Mr. Sunil for providing the excellent platform on behalf of NTOD that made this webinar possible and accessible to all the participants. Thank you all for contributing to this excellent learning curve. Thank you so much.
Thank you. Thank you.
Thank you. Thank you so much. Nice
We are
meeting.
unofficial or